tonight.
I had the mammogram. I wasn't expecting to find anything.
I did a breast exam.
I didn't have any lumps.
It wasn't a lump like all women are trained and told to look for.
An ABC 27 special presentation.
I didn't have a family history. I gave birth to 2 children and nursed them both.
One night at 2 o'clock in the morning, I just woke up and it just hit me at that time. I have cancer.
Hope and Courage, a tribute to breast health, sponsored by Penn State Cancer Institute.
Good evening, everyone. I'm Amy Kem. What does it mean to be a survivor? Tonight, you will meet 2 women who battled breast cancer and survived. You'll watch their journey of hope and courage. Why is it so important to detect breast cancer early, and how have changes in technology made it easier to detect breast cancer? You'll find out tonight. Our first story of hope and courage takes us to Lebanon County. Kathleen Ryland exercised, ate right, and nursed her 2 children. She never thought cancer would be on her radar. Here's Kathleen's story.
This is how Kathleen and Ken Ryland spend their free time. They've been biking since they got married.
It's one of the things we did on our honeymoon. We went biking.
People thought we were crazy because we went to Italy and started in the northern part of Italy near Venice. It was something that we both enjoyed and we did it together, and we saw wonderful places and had great experiences that we wouldn't have had if we weren't on bikes.
So that's something that has stayed with us after 20-some years of marriage, and still enjoy it.
An active lifestyle that took a detour when Kathleen did a self-breast exam.
I felt a change in density in my right breast. It wasn't a lump like all women are trained and told to look for, so I wasn't alarmed. But I knew that it wasn't symmetrical, and I knew that it wasn't there before.
I didn't think that it would amount to much, but you know, better to be safe than sorry, as they always say. Get it checked. So advised her go get it checked and make an appointment.
Kathleen did just that. She made an appointment for a mammogram.
This is Kathleen's mammogram. As you can see, there's a small triangle on that mammogram. That's pointing to the lump that she's feeling. Directly behind that pointer, you can see an area of increased density showing that brighter white tissue.
That same day, Kathleen had an ultrasound.
She started clicking and measuring, and I felt this wave of fear, cold fear wash over me, and knew something was not right.
More testing needed to be done.
She subsequently underwent biopsy of that mass, which showed invasive lobular carcinoma. Invasive lobular carcinomas can often be difficult to detect on mammogram, so we use MRIs to truly delineate the extent of disease. As you can see, this area of bright white enhancement shows the tumor that was found, and it measures approximately 6 centimeters on MRI.
No woman expects to hear that she has breast cancer, and it was surreal. It was hard to comprehend.
It's a blow when you hear the word cancer and you think that you're healthy and you're, you think you're still young, you're in your early 50s and you're just beginning to think about retirement and everything, and you hear that cancer word, it really takes you back.
I didn't have a family history. I gave birth to 2 children and nursed them both, and was active and ate well, I thought. I did everything that I thought I was supposed to do to be healthy.
Kathleen had to make some difficult decisions.
Because of the size of the tumor, it was something that wasn't amenable to a lumpectomy, so we recommended a mastectomy with a sentinel node biopsy.
Kathleen felt, and Dr. Witters had told her, that this particular type of cancer does have a higher rate of reoccurrence, and she made the decision to have a bilateral mastectomy.
I just felt that it was the right decision for me to do a bilateral mastectomy to reduce the risk, and hopefully I would never have to face that again.
2 months after being diagnosed, Kathleen was scheduled to have surgery.
It just doesn't feel like it could be happening, but it's happening. And I just surrendered to God. If that was His will for me, and doctors were going to do their very best and do what they do well, that I would have to trust that the outcome would be good.
I forget what happened, but I remember going to the garage and I was calling family and friends and just breaking down in the garage and crying because, there's nothing you can do. Your partner is going through surgery and it's cancer, and there's always a possibility that something could happen. You hope it doesn't, and it's just a normal procedure, but that just kind of all hit home at that point.
Because of the location of our tumor being away from the nipple, we were able to save the entire skin and nipple and do a nipple-sparing mastectomy and start implant-based reconstruction at that same time. On final pathology, we ended up finding a 5.5 centimeter invasive lobular carcinoma, and we found 1 lymph node out of 2 that had evidence of micrometastatic disease. Because of the large size of her tumor being greater than 5 centimeters and 1 lymph node showing evidence of metastatic disease, we did recommend post-mastectomy radiation.
This was some news Kathleen wasn't expecting.
I was hoping not to have radiation or chemotherapy, but when it comes down to it, survival. Women do what they have to do.
Radiation is X-rays that are aimed at a part of the body where there was cancer originally, because there's always a chance that after a surgeon removes an area with cancer, there could be microscopic cells left behind. So radiation can kill off those microscopic cells.
Kathleen went for radiation treatments 5 days a week for 5 weeks.
Radiation basically works by killing off cancer cells as they try to divide. And cancer cells are actively growing and dividing more than normal breast tissue is. So normal breast cells are able to repair any damage from radiation, where cancer cells are unable to repair damage and then they die.
Kathleen and Ken vividly remember the last treatment.
I was walking down the corridor after the last treatment, and they actually have a bell mounted to the wall, so sort of your departing gift and celebration as you have your last treatment. You ring the bell, and I just felt this sense of relief.
She was fine. She rang the bell, and we got halfway down the hallway, and she just collapsed, in tears and overwhelmed with emotions.
It was just like another hurdle done behind me in my rear view.
Many hurdles overcome. Now Kathleen and Ken can get back on track and be active again.
She's great. She's doing great. It's coming up on the end of the first year, and I think she's made great progress.
I am grateful for every sunrise, to see my children. Physically, I'm feeling stronger. I'm beginning to do more physical activity, which I enjoy. I cycled, I swam, did yoga, was active, and I miss those things. So I'm starting to do those things. I may not be able to do them at the intensity or the endurance I once had, but I'm grateful to be doing any of them to some degree.
And Kathleen is getting stronger every day. 2 weeks ago, Kathleen and Ken were in a 62-mile bike race in Maryland. She finished it, and she was happy with her time. Well, joining us tonight, we have breast surgeon Dr. Christina Witters and radiation oncologist Dr. Jennifer Rosenberg. Dr. Witters, Kathleen is doing well, thanks in part to that self-exam. How important is it for that early detection?
Yes, it is great to hear how well Kathleen is doing. Early detection is key. When a breast cancer can be caught early, it really improves your ability to fight the disease. Breast exams, as in Kathleen's story, as well as clinical breast exams, mammograms, and risk assessments are really crucial to catching the disease early. It is recommended that women 40 years and older undergo annual mammogram as well as clinical breast exam. And women who are higher risk, we really recommend that they talk to their doctor about developing a personalized screening plan.
Very good. And Dr. Rosenberg, how many different types of breast cancer are there?
So there are two different types of breast cancer. There's ductal cancer, which is present in about 85% of women at diagnosis, and there's lobular cancer, which is present in about 15% of women at diagnosis. But not just the type of breast cancer, but that is only one of the factors that go into how we develop an individualized treatment plan for each person. So in general, patients with early stage breast cancer can have a mastectomy where the breast is removed, or they can have a lumpectomy where only the tumor is removed and then radiation is delivered afterwards to the breast.
I mean, there are so many options. So when somebody is first diagnosed, what happens?
When someone is first diagnosed, as in Kathleen's story, it can be incredibly scary and overwhelming. Patients meet with various members of our team, including our specialized nurses, radiologists, medical oncologists, radiation oncologists, and surgeons, who all specialize in breast health. We then try to develop an individualized plan specific to that patient's breast cancer and come up with the plan that's best for them.
That is a lot though. So how, Dr. Rosenberg, is this all coordinated?
So all of the patient's breast cancer specialists, we meet weekly at a meeting called a tumor board. And at the tumor board, there's all the patient's physicians, as well as clinical trials nurses, geneticists, nurse coordinators, and we speak about each patient and come up with an individualized treatment plan for each person.
Very good, great information. Thank you both for being here with us tonight. Now let's check in with Carrie Perry. She's over in the ABC 27 call center. Carrie.
Hey, Amy. Well, the phone lines are busy. They are calling, a lot of people calling in. If you have a question, you can call 717-346-3333. And here to answer your viewer questions tonight is breast surgeon Dalila Dodge. Thank you so much for being here, Dr. Dodge.
I'm delighted.
Let's get to this question. I lost my job last winter and cannot afford health insurance. I'm 46 with a family history of breast cancer and I'm overdue for a mammogram. Would the Med Center allow me to get a mammogram?
The answer is absolutely yes. Through a very generous grant from Weiss Markets, we have a program for screening mammograms for women who don't have insurance. And then on top of that, we belong to the Healthy Woman program. So we have the ability to do the diagnostic workup for these women. So we encourage her to come in and get her mammogram done.
Thank you so much, Dr. Dodge.
You're watching Hope and Courage, a tribute to breast health on ABC 27, sponsored by Penn State Cancer Institute.
Welcome back. Our next story of hope and courage takes us to Lancaster County. Audrey Estep went for her annual mammogram. She expected to be in and out, but her appointment lasted much longer. Here's Audrey's journey.
There's one with pollen. They're flapping their little wings, communicating to each other. They're pretty vigorous.
In the midst of the buzzing, this is where 49-year-old Audrey Estep finds peace.
I just love the serenity to sit and watch what's going on, just to be there, to be present. And I think many times we're looking for a place of quiet rest. And if we just go to our backyard and we sit there and see nature.
A place of comfort that Audrey needed after going for a routine mammogram.
I'm thinking, well, I'll be in and out and I'll get on with my Christmas shopping, you know, the following day. I didn't think that they would find anything because I did check my breasts. I didn't have any lumps, bumps, nothing that felt unusual to me.
But they did find something.
On her screening mammogram, she was noted to have calcifications of the breast. These bright white spots here, they're very faint and very hard to see. Those are the areas of calcifications. I often describe them to patients as grains of sand that can't be felt or can't be seen with the naked eye.
They decided at that time also to do an ultrasound of my left breast. And at that time, they did not confirm that it was cancer, but scheduled me back a few days later to have a biopsy.
A little concerned, you know, we didn't have a definite yet, you know, still concerned, you know, it's always, like I say, it's always a possibility.
The biopsy confirmed Audrey and Randy's worst fear.
They called for me and my husband to come back in to review the pathology report. And at that time, the pathology revealed that I did have the ductal carcinoma in situ, which was estrogen and progesterone positive.
It kind of takes your breath away. It's something you don't expect. I mean, it's always a possibility, but we knew we could deal with it.
Dr. Witters scheduled an MRI to see the extent of the cancer.
she made the appointment, and I made sure I was going along with her for that, to be there with her.
I know when I went to have the MRI done, that was probably one of the most anxious times that I had. And as I laid in the MRI, I just kept thinking, the Lord is my shepherd. I lack nothing. And I knew at that time that there was peace and comfort and that I had nothing to fear, no matter what was found.
Here on Audrey's MRI, you can see about 7 centimeters of enhancement, indicating the extent of her calcifications and extent of that early breast cancer.
I didn't really break down until one night at 2 o'clock in the morning as I was laying in my bed, and I started to cry. And I thought, oh, my father was struggling with Alzheimer's. I thought, how am I going to tell him? How will he understand? And who's going to take care of him? That was when I really started to process and to understand that I have cancer. And how does this look and how does this feel? And what am I going to do with this?
Many questions that needed to be answered.
We reviewed whether I was going to have a mastectomy or a lumpectomy, and I chose to go with the mastectomy because the area was larger.
Audrey was scheduled to have surgery a month after being diagnosed.
Well, we prayed before we left, cried, we both cried, you know. It's a major step.
To have my breast removed, it was scary.
We offered Audrey the option of mastectomy with or without reconstruction, as we do all our patients. She opted to proceed with reconstruction. We did find some areas where the cancer had left the ducts and formed invasive ductal carcinoma, as well as a lymph node that was involved with breast cancer. So her stage did increase at time of final surgery.
She suggests that I do chemotherapy and also another medication, which is a biologic that destroys protein for the HER2 positive, that makes the cancer more aggressive.
We wanted to personalize the treatment for Audrey. We knew she had an aggressive cancer, the HER2 positive cancer, but on the other side she had an early stage cancer, stage 1. We picked a regimen of chemotherapy for her that would be less toxic for the heart specifically, but would allow her to have as good as an outcome with a more aggressive regimen.
At the time when I was going through chemotherapy, I lost my hair, my eyebrows, my eyelashes. I lost the hair all over my body. But I was okay with that.
Audrey was okay, but Randy wasn't.
She came down and she said it's time to cut her hair off, and I said I'm not ready. So we waited a little while, and she went back up and she started, and she said, you're gonna have to come up here and finish it. So I came up. It was tough to see that for me.
Audrey went through 12 weeks of treatment. Her dad was with her for one of them.
My dad said, I'm going to go along. And my mom said, oh, that's all right. And he said, no, I'm going to go. He said, because I know Audrey will feel better if I am there. So they took me back and dropped me off. And that was the only time my dad went. But he knew that as his little girl, I still needed him.
Support from family and support from her colleagues. During chemotherapy, Audrey was in seminary taking a class called God and Suffering.
And the paper that I was writing was about women in breast cancer and feeling isolation and loneliness. And I asked my professor if I could write on this, and he said, absolutely. I said to write my feelings and how we might be able to provide better care for women going through breast cancer.
Some of those words were put into practice on Audrey's last day of treatment.
She got to ring the bell, to say you're finally done with the chemotherapy. And we were walking out, and there was a lady sitting there, and my wife said it was my last treatment, and she said it was her first treatment. My wife said, you'll do fine. You'll get through it, is what she said.
Cancer is not our identity.
It helps to form our journey. I'm still Audrey, but I'm Audrey and I've battled cancer and I've survived.
You may be surprised to hear this, but Audrey says cancer was a gift. This past May, Audrey graduated with a Master of Divinity degree. As a pastor, she wants to use her breast cancer to experience a help for other people. Now joining us, we have medical oncologist Dr. Christina Tarika. Dr. Tarika, as we learned earlier, each type of breast cancer is treated differently. Can you explain to us how treatment is personalized for each patient?
We evaluate several factors, including the family history, the type of cancer, how early it was caught, how aggressive it is. In hormone-positive cancers, we perform an oncotype test, which allows us to test the cancer genes and to understand which genes are active, and helps us determine the best treatment and also the risk of recurrence.
Let's talk about risk. How can you determine someone's risk?
You know, every woman has some risk of determining breast cancer. It is very important to understand your family history because this is the most important risk factor for breast cancer. A strong family history of breast or ovarian cancer may increase your risk of developing breast cancer. We do offer a cancer clinic for risk assessment that will help you identify your risk. It includes a genetic counselor, a medical oncologist, and a nurse practitioner that will work with you to identify your risk and develop a personalized care plan and based on your factors.
Very good. Thank you so much.
Here's the question. Is there any research currently to find a test to detect breast cancer before it actually develops?
There isn't a test currently, unlike prostate cancer, for a blood test to detect breast cancer, though we're always looking for something. We haven't found it. But you know, genetic testing allows those people who have a high risk to find out whether they carry a gene, and that's a form of testing that one should consider if they have a family history.
Okay, wonderful. I've got one more for you. It's kind of a two-parter. Two friends of mine originally had breast cancer over 7 years ago and have been taking tamoxifen. Recently, their cancer returned. Does tamoxifen stop working? And are there new medications available to replace tamoxifen?
So the medications don't as much stop working as the cancers morph and change to be resistant to certain medications. But there is a whole nother class of medications called the aromatase inhibitors that also work against estrogen receptor positive tumors, and it can be used as long as a woman is postmenopausal, so there is definitely hope.
Thank you so much, Dr. Dodge, for answering these viewer questions. And thanks also to the specialists who are here tonight answering your calls and emails. We're going to send it back to Amy.
Thank you so much, Carrie. Now we welcome Dr. Melody Polishak. Now, earlier in the show, we talked about the importance of early detection. What are some of the newest screening, the newest detection tools?
So we offer 3D mammography, whole breast ultrasound, and MRI. They all aid in early detection and also evaluation of other breast diseases, and are particularly good technologies for dense breast tissue.
And let's talk about that. Are women with dense breasts more at risk?
They are. So over 50% of women have dense breast tissue, and they have a 4 to 5 times higher risk than women with less dense breast tissue. So those women, actually, we offer a course taught by Penn State Hershey Breast Center staff in order to let women know what that means for them.
And then in terms of someone who maybe is going through treatment or survivors, which we'd love to hear about, is there any support for those survivors?
We do have a support group. It's every second Monday from 6 o'clock to 7:30, and it's an informal way for women to meet and get to talk to each other.
That is really wonderful. That must be so encouraging, especially to share your success with each other. Absolutely. That is really great. Thank you for being here with us today. And thanks to everyone who's been here today. We also want to thank our viewers for sharing their stories. Thank you for sending in your questions. If you would like more information or you would like to schedule a mammogram at the Penn State Breast Center, call 717-531-7492, or you can go online to PennStateHershey.org/breast. Thank you for watching tonight. We wish you all good health. Have a great evening.